Hello, my name is Dr. Maurie Markman. I'm a medical oncologist from Philadelphia, Pennsylvania. Thank you for taking a few minutes to watch this video, as I'd like to discuss the importance of HRD testing in advanced ovarian cancer.
LYNPARZA is indicated in combination with bevacizumab for the maintenance treatment of adult patients with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with homologous recombination deficiency HRD-positive status defined by either a deleterious or suspected deleterious BRCA mutation and/or genomic instability. Select patients for therapy based on an FDA-approved companion diagnostic for LYNPARZA. Please see the important safety information throughout this video and complete prescribing information, including medication guide, at the links provided with this video or at www.azpicentral.com. Important safety information. Contraindications. There are no contraindications for LYNPARZA. Warnings and precautions. Myelodysplastic syndrome, acute myeloid leukemia, MDS-AML, occurred in approximately 1.2% of patients, 26 of 2,219, with various BRCAM, GBRCAM, HRR gene-mutated or HRD-positive cancers who received LYNPARZA in clinical studies as a single agent or as part of a combination regimen consistent with the approved indications, and the majority of events had a fatal outcome. The median duration of therapy in patients who developed MDS-AML was approximately 2 years, range less than 6 months to greater than 4 years. All of these patients had previous chemotherapy with platinum agents and/or other DNA-damaging agents, including radiotherapy. In SOLO-1, patients with newly diagnosed advanced BRCAM ovarian cancer, the incidence of MDS-AML was 1.9%. 5 of 260 in patients who received LYNPARZA, and 0.8%, 1 of 130, in patients who received placebo based on an updated analysis. In PAOLA-1, of patients with newly diagnosed advanced ovarian cancer with HRD-positive status, the incidence of MDS-AML was 1.6%, 4 of 255, in patients who received LYNPARZA, and 2.3%, 3 of 131 in the control arm. In SOLO-2, patients with BRCAM platinum-sensitive relapsed ovarian cancer, the incidence of MDS-AML was 8%, 15 of 195, in patients who received LYNPARZA, and 4%, 4 of 99, in patients who received placebo. The duration of LYNPARZA treatment prior to the diagnosis of MDS-AML ranged from 0.6 years to 4.5 years. Do not start LYNPARZA until patients have recovered from hematological toxicity caused by previous chemotherapy, less than or equal to grade 1. Monitor complete blood count for cytopenia at baseline and monthly thereafter for clinically significant changes during treatment. For prolonged hematological toxicities, interrupt LYNPARZA and monitor blood counts weekly until recovery. If the levels have not recovered to grade 1 or less after 4 weeks, refer the patient to a hematologist for further investigations, including bone marrow analysis and blood sample for cytogenetics. Discontinue LYNPARZA if MDS-AML is confirmed. Pneumonitis, including severe and fatal cases, has occurred in patients treated with LYNPARZA. In clinical studies, among patients who received LYNPARZA as a single agent or as part of a combination regimen, the incidence of pneumonitis, including fatal cases, was 1.0%, 29 of 2,851. If patients present with new or worsening respiratory symptoms such as dyspnea, cough, and fever, or a radiological abnormality occurs, interrupt LYNPARZA treatment and promptly assess the source of the symptoms. If pneumonitis is confirmed, discontinue LYNPARZA treatment and treat the patient appropriately. Venous thromboembolism, VTE, including severe or fatal pulmonary embolism, PE, occurred in patients treated with LYNPARZA. Monitor patients for signs and symptoms of venous thrombosis and pulmonary embolism and treat as medically appropriate, which may include long-term anticoagulation as clinically indicated. Hepatotoxicity, including drug-induced liver injury, DILI. Hepatotoxicity, including severe and potentially fatal cases of DILI, has occurred in patients treated with LYNPARZA. Evaluate bilirubin and transaminases at baseline and throughout treatment with LYNPARZA. For patients who develop abnormal liver tests after LYNPARZA, monitor more frequently for liver test abnormalities and clinical signs and symptoms of hepatic toxicity. If DILI is suspected, withhold LYNPARZA. Upon confirmation of DILI, discontinue LYNPARZA. Embryo-fetal toxicity. Based on its mechanism of action and findings in animals, LYNPARZA can cause fetal harm. Verify pregnancy status in females of reproductive potential prior to initiating treatment. Females. Advise females of reproductive potential of the potential risk to a fetus and to use effective contraception during treatment and for 6 months following the last dose.
First, I'd like to discuss how HRD testing can help inform treatment decisions and identify patients eligible for targeted treatment options. Homologous recombination deficiency, or HRD, is an important characteristic of advanced ovarian cancer. Approximately 1/2 of all patients with high-grade serous advanced ovarian cancer have HRD, defined by the cell's inability to repair DNA damage. Approximately 1 in 4 women with advanced ovarian cancer will in fact have a BRCA mutation, either germline or somatic. Another approximately 1 in 4 women will have another genomic instability aberration without a BRCA gene mutation. All women with a BRCA mutation are HRD positive by definition. Cells with a BRCA mutation are unable to repair DNA effectively. However, importantly, not all women who are HRD positive will have a BRCA mutation. Half of women who are HRD positive will not have a BRCA mutation, but will have genomic instability. Again, it is important to note that 1 in 2 women with advanced ovarian cancer, when tested, may be HRD positive and may be eligible for LYNPARZA plus bevacizumab. It is important to note that HRD can be identified via 3 distinct but related components. The first, which is probably the most well known, are germline mutations in the BRCA genes, BRCA1 and BRCA2, which are inherited. The second is acquired BRCA mutations. These mutations are only within the tumor cells, acquired as part of the development of the cancer, and not within the germline. The third component of homologous repair deficiency is alterations related to genomic instability. Like BRCA mutations, genomic instability may also result in a cancer cell's inability to repair DNA damage. The 3 general categories of these broad structural genomic aberrations include loss of heterozygosity, large-scale state transitions, and telomeric allelic imbalance. Importantly, germline BRCA mutations, somatic BRCA mutations, and/or genomic instability identify HRD and help determine if patients are potentially eligible for treatment with LYNPARZA and bevacizumab. The FDA-approved companion diagnostic for LYNPARZA and bevacizumab is the Myriad MyChoice CDx, which identifies BRCA status along with all 3 components of genomic instability. Gene panels without measures of genomic instability do not capture all HRD status and are not FDA-approved companion diagnostics for LYNPARZA. Next, let's discuss why HRD testing is important in advanced ovarian cancer. As I've mentioned, there may be important implications of finding these molecular abnormalities, but what precisely are these implications? The first are familial implications. If a patient is found to have a BRCA mutation based on HRD testing, additional testing could determine if it is a germline mutation, which is hereditary and very well could have been inherited by the patient's children or other family members. Therefore, the importance of germline BRCA testing here relates to a person's risk of developing certain types of cancer as well as familial risk implications. This leads into not only genetic testing of other individuals, but also genetic counseling. Turning specifically to the patient in question, there are certain mutations, including BRCA mutations, that may have prognostic implications that are important for patients to discuss with their oncologist. Finally, and specifically for the intent of this discussion, are the very specific directed therapeutic implications for patients with advanced ovarian cancer. For example, HRD-positive disease is associated with varying degrees of sensitivity to platinum chemotherapy and/or PARP inhibition. Additionally, LYNPARZA plus bevacizumab has been approved by the FDA for the maintenance treatment of patients with HRD-positive advanced ovarian cancer after complete or partial response to first-line platinum-based chemotherapy. NCCN guidelines recommends testing for HRD in the upfront setting in the absence of a BRCA1 or 2 mutation, as it may help inform usage of PARP inhibitor therapy. I'd like to go a little bit into the proposed mechanism of LYNPARZA, a PARP inhibitor, in HRD-positive advanced ovarian cancer. This is important not only for our knowledge as clinicians about why we're ordering these tests, but also for patients and families who are going to ask these questions. As ovarian cancer cells proliferate, they accumulate DNA damage. In all cells, there are a variety of DNA repair mechanisms, one of which is through an enzyme known as PARP. The goal with PARP inhibitor therapy, such as LYNPARZA, is to interfere with the repair process in these tumor cells. The absence of homologous recombination repair, or HRD, and a functional PARP-dependent DNA repair pathway are both thought to lead to cell death. LYNPARZA may also affect healthy cells and tissues in the body. The exact mechanism of action of LYNPARZA remains a subject of research. You now understand many aspects of the biology of HRD and the implications of testing for this important biomarker. But what do clinical guidelines say regarding HRD testing? NCCN guidelines recommend germline and tumor testing for BRCA1 and BRCA mutations in all patients with ovarian cancer. Testing for HRD status at diagnosis helps inform first-line maintenance treatment with olaparib, LYNPARZA, and bevacizumab. In the absence of a BRCA mutation, HRD testing may provide information on the usage of PARP inhibitor therapy.
Adverse reactions. First-line maintenance advanced ovarian cancer in combination with bevacizumab. Most common adverse reactions, grades 1 through 4, in greater than or equal to 10% of patients treated with LYNPARZA bevacizumab, and at a greater than or equal to 5% frequency compared to placebo bevacizumab in the first-line maintenance setting for PAOLA-1 were nausea 53%, fatigue including asthenia 53%, anemia 41%, lymphopenia 24%, vomiting 22%, and leukopenia 18%. In addition, the most common adverse reactions, greater than or equal to 10% for patients receiving LYNPARZA bevacizumab, irrespective of the frequency compared with the placebo bevacizumab arm, were diarrhea 18%, neutropenia 18%, urinary tract infection 15%, and headache 14%. In addition, venous thromboembolism occurred more commonly in patients receiving LYNPARZA bevacizumab 5% than in those receiving placebo bevacizumab 1.9%. Most common laboratory abnormalities, grades 1 through 4, in greater than or equal to 25% of patients for LYNPARZA in combination with bevacizumab in the first-line maintenance setting for PAOLA-1 were decrease in hemoglobin 79%, decrease in lymphocytes 63%, increase in serum creatinine 61%, decrease in leukocytes 59%, decrease in absolute neutrophil count 35%, and decrease in platelets 35%.
Next, I'd like to discuss the point that HRD tests are not interchangeable and different assays have different measures of genomic instability. It's very important that you're aware of what information you will be obtaining when you order an HRD test. Myriad MyChoice CDx is currently the only FDA-approved companion diagnostic for determining HRD status and eligibility for LYNPARZA plus bevacizumab. In the Myriad MyChoice CDx, HRD-positive status is defined by either a deleterious or suspected deleterious BRCA mutation and/or genomic instability via a combined genomic instability score. This test does not include PD-L1 status, non-BRCA HRR mutations, MSI, TMB, or NGS panel testing. These biomarkers are not used in determining eligibility for LYNPARZA plus bevacizumab.
Drug interactions, anti-cancer agents. Clinical studies of LYNPARZA with other myelosuppressive anti-cancer agents, including DNA-damaging agents, indicate a potentiation and prolongation of myelosuppressive toxicity. CYP3A inhibitors. Avoid co-administration of strong or moderate CYP3A inhibitors when using LYNPARZA. If a strong or moderate CYP3A inhibitor must be co-administered, reduce the dose of LYNPARZA. Advise patients to avoid grapefruit, grapefruit juice, Seville oranges, and Seville orange juice during LYNPARZA treatment. CYP3A inducers. Avoid co-administration of strong or moderate CYP3A inducers when using LYNPARZA. Use in specific populations. Lactation. No data are available regarding the presence of olaparib in human milk, its effects on the breastfed infant, or on milk production. Because of the potential for serious adverse reactions in the breastfed infant, advise a lactating woman not to breastfeed during treatment with LYNPARZA and for 1 month after receiving the final dose. Pediatric use. The safety and efficacy of LYNPARZA have not been established in pediatric patients. Hepatic impairment. No adjustment to the starting dose is required in patients with mild or moderate hepatic impairment. Child-Pugh classification A and B. There are no data in patients with severe hepatic impairment. Child-Pugh classification C. Renal impairment. No dosage modification is recommended in patients with mild renal impairment. CLCR 51 through 80 milliliters per minute estimated by Cockcroft-Gault. In patients with moderate renal impairment, CLCR 31 to 50 milliliters per minute, reduce the dose of LYNPARZA to 200 milligrams twice daily. There are no data in patients with severe renal impairment or end-stage renal disease. CLCR less than or equal to 30 milliliters per minute.
In summary, there are some very important points I'd like to leave you with. The first is that HRD testing may help inform treatment decisions and identify patients for targeted treatment options. Here we are talking specifically about PARP inhibition. Also, it's important to understand that HRD is associated with varying degrees of sensitivity to platinum-based chemotherapy and/or PARP inhibition. Additionally, LYNPARZA plus bevacizumab is approved for the first-line maintenance treatment of certain patients with HRD-positive advanced ovarian cancer. It's also important to recognize that not all HRD tests are the same and to understand what information each test provides. Myriad MyChoice CDx is the companion diagnostic for LYNPARZA plus bevacizumab and is the only FDA-approved tumor test that measures all 3 markers of genomic instability we discussed previously: LOH, LST, and TAI. I cannot overstate the importance of HRD testing in advanced ovarian cancer. Thank you for listening today, and I hope you found this discussion to be valuable.
Please see the important safety information throughout this video and complete prescribing information, including medication guide at the links provided with this video by scanning the QR code or at https://www.azpicentral.com/pi.html/product=LYNPARZA_TB. You are encouraged to report side effects related to AstraZeneca products by calling 1-800-236-9933. If you prefer to report these to the FDA, please call 1-800-FDA-1088.